hand fractures so close to my heart simply because every time I see a hand fracture, I know that in some consultant's room, he's telling his subordinate, just strap him. And the subordinate straps him like this, or then says, no, we have some splints. So he splints it like this, or like this. And this morning we were discussing about how splints can go very wrong, and this is one of those. Then of course there is the ball bandage, where someone said, "Arey ball bandage banana hai to put a ball inside, no? Saath mein exercise bhi ho jayega, smiley ball." So the thing is, we do not pay attention to this fracture. And unfortunately, if you don't pay any attention, this is what can happen, and the hand can get very, very stiff. Sometimes we have the courage and we say, no, we want to put in a wire, and then we put in wires like this. And hopefully by the end of this talk, maybe I will have changed a little bit about how you look at hand fractures and how you give them some attention that they deserve. How do I treat a hand fracture? I first obviously assess it, reduce it, stabilize it, mobilize it. Nice words, all of us use these, but we have absolutely no clue what I'm talking about, simply because all these words are subjective. So let's put some objectiveness into the way we look at hand fractures. So that's a tough fracture to fix. And on the so-called lateral view, it looks acceptable. So should I just accept it? But then when you clinically look at the patient, you realize that when he flexes, there's a dynamic deformity, it's getting worse. X-rays are done in the most absurd way in all hospitals across the world. You don't have a lateral view, you've got two views, you're happy, you want to just get rid of this guy, just strap him, send him away. So the first step is to get good X-rays. This is the conventional way when a hand injury goes for an AP and a lateral view, and the most stupid way in which you can get a lateral view. Look at the lateral view, there's nothing that you can make out. If you want to see all fingers, normally one finger is injured, just get a good lateral view of that finger. But if you want to see all the fingers, then lift the hand off the plate and keep the fingers in different varying flexion angles. You'll get a lateral view of every single joint in the hand. So beautiful. You'll never miss a fracture then. Let's come back to this fracture. Why am I talking about this fracture? Because when I took a lateral view, can you imagine this was what was hiding behind this? And this guy was only strapped and sent away. Next, we need to understand the fracture, for which, again, classifications are very difficult to understand. So I have this very practical assessment, which is not my own, which came from an old publication which I have completely forgotten where it came from, but it's been in my slides from the days of Ektachrome, and I've maintained this. Which bone is affected? Where in that bone? Intra or extra-articular, displaced or undisplaced, stable or unstable? Is there a deformity, obviously, or is there a dynamic deformity? So let's look at each of these. If there is a soft tissue involvement, you add that and say whether it's open or closed. If there's a displacement, you say displaced or undisplaced. If it's impacted, you must make a note of that. See what type of a fracture it is it transverse, oblique, spiral, etc. Where in that fracture, in the head, neck, shaft, base, all of this makes a big difference. And then which bone? So then if you take one from each, one word from each of these brackets, and you put it, you have an absolutely descriptive assessment of a hand fracture. A closed, undisplaced, oblique fracture of the shaft of the thumb or index. Now that makes meaning. That tells you what you're going to do. So you must see that. Next, is it stable or unstable? If it's stable, you're not going to give the advice of surgery. And if it's unstable, you're trying to reduce it to see whether it then becomes stable, so that you can treat it. Such a simple thing. You must see the unstable fractures, try and reduce them, make them stable. If it's not stable, then you think in terms of fixation. So that's how you will think about it. So each step takes you closer to the answer of how you're going to treat it. Stable. What is stability? It's nice, it's a subjective word again, but this paper, which is 1987 and still one of my go-to papers for finding out whether it's stable or not, if there's 50% of active range of movement in the joint above and below the fracture, if there's sufficient stability in motion, that means there's no dynamic deformity and there's no malrotation, these fractures are amenable for conservative treatment. So now you have objective data to tell you, or objective ideas to tell you, which ones you're going to consider as stable and which ones you're not going to consider as stable. So don't forget these 3 points. These 3 points are extremely important for every single fracture. Let's take an example of this fracture to fix this or not to fix this. Fix or not? Nobody. Food. Postprandial. Fix. I'm going to add some, this is a hypothetical situation. It's a 72-year-old man. Still fix? God knows. Non-dominant hand. Sir, जाने दो ना यार, 72 years old है. Parkinson's है, अरे बाप रे. Uncontrolled diabetic. On blood thinners. Exactly, someone said stability. Don't forget stability. First, reduce, reassess. Reduced, well hitched, well aligned, no malrotation. Apply the same criteria. This man is going to do well. You do not need to fix it. So every fracture that you see need not be fixed. You need to understand there are other things behind and then treat these fractures. So don't make a decision to operate before seeing the entire picture. When you look at x-rays like this, you should see, if you look at the x-ray on the right and you see the phalanx that is not affected, you see the joints are stacked up one upon the other and they're absolutely parallel. Whereas the one that's injured is rotated. So this one requires reduction. And if you reduce it, and this is a child, so the periosteal sleeve is good. If you reduce it, the joints will then stack up one on top of the other perfectly well for you to now conserve this and get a good result. After you've done the reduction, how do you strap it? We saw some absurd strappings before, but the way in which you're going to strap this is that you take micropore, not dynaplast, micropore, not dynaplast, micropore, not dynaplast, please. Yeah, when you try to remove the dynaplast, you displace the fracture again. So micropore is the easiest, 1 centimeter in the phalangeal spaces, not over the creases. You can see the joint is open because that skin is required to flex and extend, and that's the only way a strapping is going to work. Buddy tape it and then give a nice bulky dressing. Don't leave it like that. The position in which the hand goes when it's injured is with the wrist in flexion and the MP joints in extension, and that's the position where the joints can take the maximum amount of fluid. That's why it's the position of rest or position of comfort, which is nonsense. Because your MP joints are in extension, you're going to get MP joint stiffness because of the collateral ligaments being not along the center. So they are eccentric and therefore they are towards the dorsum. They need to be kept flexed or completely stretched out. After that, you give a plaster slab on the back, even for a single finger fracture. That's the way you avoid stiffness. And then you can get the patient to move immediately like this. What about the unstable ones? Well, you try and reduce it, it's not falling into place, you need to put in a pin, put in 1 pin. So hold the finger, push up the base, go antegrade, go on either side, one or the other side of the extensor tendon like this. Mark out the extensor tendon. Yes, edema, you cannot see it, but you know where it is. You've seen it 100 times. So go avoid it. Pass the wire along the plane in which it will go into the shaft. 1 wire, stable. Go back to your buddy taping, go back to the gamgee, and there you are with an excellent result. Remove the wire. There's no tethering of the extensors because you've done all of this with the MP joint in flexion. Like you do Elizarov, when you're going in from one compartment, you stretch the muscles in that compartment. And then when you come out from the opposite compartment, you stretch the muscles in that compartment. Similarly, you're stretching the extensor hood, therefore there's no there's no tethering, and there's no extension lag. This is more difficult. Multiple unstable fractures. So what do? Multiple wires. But this will give stiffness definitely, won't it? I don't think so. If you treat them the way we did, you can see the marks, the wires have just come out, and you can get no extensor lag and excellent function. Wires should never be used to distract bones. If you distract the bones, you're going to have a lot of problems. Phalangeal bones and metacarpals do not tolerate distraction. They will go into a non-union. So do not allow distraction to be there. Let there be contact of as much surface as possible. What about these? Are they amenable to screw fixation? Are they amenable to screw fixation? This is from the AO surgery reference. And yes, they are, if you have the proper screws, if you're going to open it, and then you're going to follow it up with a very robust mobilization program, because once you violated the extensor tendons, you're going to have stiffness. So you must avoid stiffness. What about doing this in a very a sportsman or an athlete who's playing, or contact sports, cricket and other sports like basketball, etc. These screws sometimes can be worrisome and will require removal, another surgical procedure. So therefore, you can also think in terms of using wires just like you would use screws. So multiple wires, not a no-no, but in the right place. So interfrag screws, interfrag wires. Wires are just like screws without threads and heads. Wires are just like screws without threads and heads and can be removed easily. So therefore, you should use them just the way you would use screws, and you'll get good function. Wires. Oh, what kind of wires? Oh, just take a wire and put it in. It's a bloody wire. Who cares? No, care for this wire, because the tip of the wire is extremely important. Unless the tip of the wire crosses the far cortex completely, you're not going to get that hole filled up. You see the holes are there on the right side. So if it's a bayonet or a long trocar, you see how this area is not covered. That means there's no contact between metal and bone, and that means there's loose space there. That means there's failure of the wire, and the entire length of the sharpened portion has to come out from the opposite side. Sorry, unfortunately, in the hand there is not much space. There's something on the other side that's going to get rubbed, that's going to have a problem. So be careful, use short trocar tip wires. The tip does not drill. The tip does not drill. The tip provides the pivot on which the cutting edges of the trocar, the 3 or 2 cutting edges of the trocar, are the cutting edges. So don't look for a sharp tip K-wire. Look for a sharp sided K-wire. Run your finger along the side. See the strength of that. So this is how you choose your wires. Choose the right size of wire. What to do with small fragments like this? Extremely difficult to control. Easy when you open it, stiffness when you open it. So is there another way? Pass an axial wire. Use that to guide the wire, the fragment back into place. More difficult when they come late. Won't sit easily. So put in your wire. Slowly bring it back into place. Once it's back in place, pin it down there. So you can get 2 pins in, get your joints in place without opening even very difficult periarticular fractures like this. Then we come to joint injuries. And this is the most difficult one. And if you understand just part of what I'm going to tell you, I think you'll save a lot of hands from a lot of distress. Number one is to understand that the condyle, when it slips out, it flips because the collateral ligament is attached to it. And then you always, when the patient is injured, you ask him to move. And when you move, you have these problems. So therefore, you should be careful that you flip it back in, either by closed. In this one, it was done by a joystick method. Just put in a thin wire and rotate it. Important to note here, the size of that wire. It's not a 1 millimeter wire. It's a 0.8 millimeter wire. It doesn't even hold in the wire driver sometimes. So you need to put it on a chuck with a zero chuck. The Jacobs zero chuck, it goes down to zero. You can hold a 0.6 and a 0.8 millimeter wire. Keep 4 of each in your set at all times. You don't know when you're going to need it. A 1, 1.2 and a 1.5 will kill an avascular necrosis of the condyle is a known fact and will kill this condyle. And you'll obviously get good results. I'm going to show you only good results, so don't look for bad results. In 20 minutes, that's what you get. If it's irreducible by any method, then you need to open it. When you open it, you need to pass in maybe wires or screws. Once you've opened it, use a screw, avoid the collateral ligament. So you go between the accessory and the main collateral ligament, pass just one when it's required, multiple when they're required, and you'll get a good reduction. Sometimes you have fractures like this which are considered minor. This is a top level cricketer. And he was made to play one more game after this injury because it was an important game. And all the games for everyone is important. And now with the IPL around the corner, I don't leave Mumbai city because IPL is my harvesting time. It is my harvest festival. Because not the 11 players who are playing on the field, the 11 million who are playing outside, because they are so encouraged. They all are playing. There's a school dads league. School children play, yes, but the dads are standing and watching. They said, no, let's play. So now there's a school dads league where all the fathers who are 30 to 45 and are all jaunty roads of a lifetime gone by, but want to prove it to their children. So they're all falling all over the place, and we're getting a lot of these injuries. So the mothers said, why not us? So throw ball and volleyball for mothers. There are leagues where you pay 2 lakhs to get onto the team. This is crazy. It's going to some other place right now. But you get injuries like this very commonly in cricket. And so this boy played one more game, and after which he was in so much pain. When he came to me, I took a fluoroscopy, and when I flexed it, you can see what has happened. It has pushed down the condyle. He's never going to have a good hand. So you need to open it. You need to put that fragment back in. You need to put in one screw. Wires won't help here. And then you need to mobilize him. There is bound to be a little bit of a flexion deformity, but he should get more or less an excellent function. Now this one has both condyles flipped. They've fractured and flipped, and they look like they will never come together. Now here what do you use? Plates. If you get a plate right up there, it's going to be right underneath the central slip, and that's going to be a problem. So I use wires. Again, multiple wires, just like I would have used screws otherwise. Now that looks like a lot of hardware in a very tiny place, but all the wires are bent, all the wires are stuck under the skin, and the patient is moving from the time I finish my surgery. I don't even wait for the next day. He's under local anesthesia. I get a video of him doing this, and I tell him, if you do not replicate this, you're not going to get a result. I take a video of that, and I send it to the patient with the pre-op and the post-op x-ray and the video. And I tell him, next time you come, you should be better than this, not worse. And if they do their exercises, they'll get much better. So remember, it's not the number of wires, it's their size and it's their position and how you deal with the post-op. And that's how he did very well. Plates. This one's really bad. Even I get scared when I look at this. In the old days, I would have used an external fixator. Some of them do well, some of them don't do well. I went in from the back. I went in from the front. You can see the small IV cannula which we use to pull the tendons apart on the volar side. From the dorsal side, I pinned the dorsal fragment first. Now I have got one unit against which I'm going to put a plate, and I've opened it out, and I've taken one of these small plates that is very handy, cut it off with a little bit of that length and bent those edges so that I got a hook plate now, and that hook plate can now be used to put that fragment back in. Looks beautiful, no? So I started mobilizing him because I'm so confident of my work, and guess what happens? Shouldn't I have also fixed that? I should have, because there is the extensor tendon attached to that. But that was where we were, this is where we are, and that's where the patient is. Fair function in a very, very difficult situation. this is the part that I would like you to take home today, and that is volar lip fractures. Best lateral view always for a PIP joint fracture. Once you see that, you look for what is known as the V sign. Look at the V over there, memorize this forever, don't ever forget the V sign. The V sign is the reason why they fail. The joint is subluxated. Once the joint is subluxated, it's not going to come back in unless you reduce it. I'm not going to go into numbers and percentages and size of the articulus fragment and where the collateral ligament is attached, etc., because that's completely theoretical and a very high level this thing for PIP joint injuries, but suffice it to understand what's happening. This cannot flex. When he tries to flex, this is what happens. You get hinged flexion. The finger will flex 15 to 20 or 30 degrees, but it's hinging. Hinging means contact pressure points are very are prone to get arthritic, and that will be a problem. So here's this patient who came to me, and we did under ring block a reduction. Congruent gliding reduction. Now my job is to maintain this with an extension block. I don't want him to go into extension because of all what I said about collateral ligaments and other things. So when you reduce, you push down the middle phalanx. This is not good. This is flexion. See the amount of flexion. From the outside when you look, there's lots of flexion. There's almost 80 degrees flexion. You're happy, aa gaya, but it's still hinging. The V sign is still there. And therefore this is wrong. What you need to get is this, gliding reduction. When you move it from that position down to 90, there's no crepitus. Feel for crepitus. Almost hear the crepitus. Then you need to just keep it in a extension block splint. Sounds like a big thing, simple, to keep the PIP joint from going back into extension in whatever way you can, and you'll get this reduction and healing, and you'll get fabulous function in this. If it's unstable in flexion, you want to hold it down because it's a patient whom you can't trust, then use nail traction like Kleinert's traction and you'll still get a good reduction. If you miss the bus and if it's very late and they come in months later like this fellow did, because this is what the reduction without anesthesia was. With anesthesia he looked okay for the surgeon who was treating him, so he put him into an external fixator. That's not a good external fixator. It's got wires that go into the flexor tendons from the dorsum, which is so crazy because he's not going to move at all. He's got a V, you can see the V sign still. So he's not got a reduction. He's also gone and violated the flexors. This is a major disaster. Size of the wires, hinging, length of the wires, lots of problems. So here is what he is with. So what you need to do is to take, in these cases, the only way out is to take a small piece of the hamate with the cartilage and the bone from the dorsum. It's called the hemihamate, and the gentleman who's sitting down is Hill Hastings, who, I don't know for what reason, he was looking at the hamate and said, "Arey, ye to PIP joint jaisa lag raha hai yaar." And he took out a piece of that. It's got a small ridge, it's got the same shape, and he transported it to this joint, and you got an osteocartilaginous autograft. So that's what we do. It's called a hemihamate arthroplasty. It's a delicate operation, but it's a easy operation for someone who knows how to get there and what to do there. You do what is known as the shotgun approach. Once you do that, you create the joint, there's no V sign, and you'll find fabulous function. So they get about 85 degrees of movement at the PIP joint. DIP joint, sometimes they can get up to 60 degrees, and there's 80 degrees of strength. And this operation is now about 20 years old, 15 or 20 years old. Quickly, I'm going to show how you dress a hand wound. You need to put gauze in between the fingers. Please always put a thin layer of gauze in between the fingers. There should be no maceration. The Gamgee pad comes, and you then need to roll your bandage from the dorsal side, from the radial side to the ulnar side, and then you'll be able to roll the thumb into the functional position, and just with bandages, without plasters, see how the hand comes into the functional position where the MP joints are in flexion, the IP joints are kept in extension, the thumb in opposition, and you can start function right away. So all fractures get this bandage. So the wrist is in 30 degrees dorsiflexion, MP joints in 45 to 60 degrees flexion, IP joints free to move, and I then ridge the plaster. Why do you ridge the plaster? Number one, you use only one plaster. Don't make it heavy. So one plaster, 8 layers, and you ridge the plaster. And why do you ridge the plaster? See this. I don't need to say anything. That's some material. That's the plaster material. It can't hold a bottle of locks. Ridge it, like the asbestos. And now you see how much strength has increased. 240% with one ridge. 240% with one ridge. Fabulous. So why not ridge your plaster and use just one plaster? Why do you need more? Finally, don't forget rehabilitation. None of these results would be half as good if there was no rehabilitation. You have to know a little bit about splints, you have to know when to use them, and you must use them. So, not all fractures that come into my consulting room are funneled into the operating room. What I would do when I see a fracture in my OPD is find out whether there's a joint involvement or not, whether it's an intra-articular fracture. Is it undisplaced? I'll put the concept of stability test which we spoke about. Then I would give him a buddy taping and slab. If it's displaced, I'll see whether it's reducible and stable. And if it is, then I'd go back to that. If not, if there is comminution, angulation, rotation, shortening, etc., I will then push him to the operating room. Intra-articular fractures, undisplaced, concept of stability, and then depending upon which you're doing, whether it's inflection or extension, you need to take care of that. If it's displaced, except the mallet, which we did in the morning, that will go into the operating room. So very few of my patients are funneled into my operating room. So in summary, keep the hand in a functional position. 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 Please, MP joints flexed, IP joints extended, wrist in 30 degrees of extension. Keep the hand in functional position. If that does not happen, if that is not done, at the end of your treatment, your patient might just, sorry,